Okay, moving on with our assessments, we want to go now. We're going to listen to the chest with the stethoscope, or we're going to auscultate. So auscultation, following the inspection, uh, listen at the mouth and nose for adequate air movement. Listen to the chest with a stethoscope. Auscultate. In the pre-hospital setting, we should auscultate the right and left apexes just below the clavicles, uh, and the right and left bases, eighth or ninth intercostal space, mid-clavicular line. Uh, the right and left lower thoracic back, or the right and left mid-axillary line, fourth and fifth intercostal space on the lateral aspects of the chest. When the patient's condition permits, you can monitor 6 locations on the posterior chest or on the back, 3 right, 3 left. The posterior surface is preferable because heart sounds do not interfere as much with the auscultation at this location. However, because the patients are usually supine during airway management, the anterior and lateral positions usually prove more accessible. Breath sounds should be equal bilaterally, and sounds that point to airflow compromise include, as we discussed earlier, snoring, results from a partial obstruction of the upper airway by the tongue. Gurgling results from the accumulation of blood, vomitus, or other secretions in the upper airway. Stridor, a harsh, high-pitched sound heard on inhalation. Note that, inhalation for stridor, associated with a laryngeal edema or constriction. This is where you hear the stridor on the little kids with croup, is a good example. Wheezing, a musical, a squeaking, or a whistling sound heard on inspiration and possibly expiration, associated with bronchial constriction. Now, I need to correct this. I said on inspiration and possibly expiration. I need to switch that around. You're first going to hear wheezing on expiration. If they are wheezing on inspiration and expiration, that is very indicative of a severe asthma attack or a severe narrowing of the bronchial pathways for whatever reason. So expiration first, inspiration is second. Quiet or is a diminished or absent breath sounds are ominous finding and indicate a serious problem with airway, breathing, or both. And this is what I was discussing earlier when we talked about silent chest. That's what they're talking about. Silent chest is very, very ominous. If your patient is alert, looking at you, having difficulty breathing, and you put stethoscope to chest and you don't hear anything and you know that they're at least attempting to move air, that is not a good day. That is a sign of extreme compromise. Sounds that may indicate compromise of gas exchange include rails or crackles, is a fine bubbling noise heard on inspiration associated with fluid in the smaller bronchioles. Then we have rhonchi, a coarse rattling noise heard on inspiration associated with inflammation, mucus, or fluid in the bronchioles. So if you think of rails as fine bubbles you would expect to hear in say something like an aquarium with a bubble stone where it makes the tiny little bubbles, and rhonchi is more the big bubbles, thicker liquid, that kind of thing. If you think about it having the mucus or fluid mixed with the mucus, and it's a harsher sound or a more coarse noise. When you assess for the effectiveness of ventilatory support or the correct placement of an airway adjunct, remember that air movement into the epigastrum is sometimes mimic breath sounds. So listening to the chest should be only one of several means used to assess air movement. Another method of checking correct placement of an airway adjunct is to auscultate over the epigastrum. It should be silent during ventilation. When you provide ventilatory support, watch for signs of gastric distension. It's the belly getting bigger. So, and during that time, you can adjust and you can guide whoever your partner is, that while they're bagging, if they're bagging too forcefully, maybe causing the gastric distension or or the respiratory noises or air movement in the epigastrum, may tell them to less forceful respirations if possible. You can guide the airway management from there. Another method of checking correct placement of an airway adjunct is, or I'm sorry, when you provide ventilatory support, watch for signs of gastric distension. We discussed that. They suggest inadequate hyperextension of the neck, undue pressure generated by the ventilatory device, or improper placement of airway adjuncts. So if you hear that epigastrium like we discussed, either the airway adjunct is not in correctly, the head is not tilted enough, if able to be tilted, or they're squeezing too hard on the bag, or if you're using a demand valve, which we'll discuss later, it's pushing too hard and pushing air past the trachea and into the esophagus. So next we're going to move on to palpation. So this is our final step. Palpate first using the back of your hand or your cheek to feel for air movement in the mouth and nose. We discussed that earlier. If an endotracheal tube is in place, you can check for air movement at the tube's adapter. That's a little part you attach to the bag valve mask to. Next, palpate the chest for rise and fall. In addition, palpate the chest wall for tenderness, symmetry, abnormal motion, crepitus, and subcutaneous emphysema. This is all part of our primary assessments and our trauma assessments, our head to toes. This is all specific to airway, though, that we're dealing with right now. When ventilating with a bag mask, gauge the airflow into the lungs by noting compliance. Compliance is how easy or difficult it is to bag this patient. So, and what it tells you is how stiff or flexible the lung tissue is. If good compliance, easy to bag, you're getting good chest rise and movement. You're getting no sounds over the epigastrium. Everything is improving. Your saturation, your end-tidal CO2, patient color and condition is all improving. You've got good compliance. Now you can have poor compliance or difficulty bagging and still create improvement or have improvement in your patient condition. However, you'll notice that they are not as compliant. You may find this in your emphysema COPD patients, that they are just not as compliant, and their airflow is just not as good, although any extra airflow you get is going to be an improvement of what they are getting at the time. It could also be upper airway obstructions that can cause difficulty with compliance. If you're not getting good compliance, of course, go back through your process, reposition the head, reevaluate your airway adjunct, whatever anything you have done. If you go back and reassess all that stuff, and they just may be poor compliance, or it may be something that was done that was not set correctly, or may not be as effective as we had hoped it would be. If ventilating a patient initially is easy, but then progressively becomes more difficult, repeat your primary assessment again. So we're constantly reassessing, and look for development of a new problem, possibly related to the mechanical airway maneuvers, because that's the thing that's changed. Is what you've done is have you gotten caught in the moment and got excited and bagging harder and faster and causing gastric distension? Or did the airway adjunct become displaced? Look for problems. The following questions will help with this assessment. Is the airway open? Is the head properly positioned in extension for non-trauma patients? Is the patient developing a tension pneumothorax? Is there signs of trauma? Is there apparent signs of trauma? Did you expose that chest and look at it? Did you see any bruising, redness, unequal chest rise and fall? Anything like that. If an ET tube is present, is it occluded? Is there a mucus plug or aspirated materials? Has the endotracheal tube been inadvertently pushed into the right or left main stem? primarily the right, but it is possible to put one in the left main stem as well. Has the endotracheal tube been displaced into the esophagus? Is the mechanical ventilatory equipment functioning properly? Is your bag functioning properly? Has something gotten up into its mechanism, or is there a mechanical flaw? Is there a manufacturer's flaw? Uh, Pulse rate abnormalities might also suggest compromise, respiratory compromise. So tachycardia, if they are tachycardic, is that uh, normal for this patient? What have they done? Did they just get done running 5 miles and now they can't catch their breath like they used to? I mean, you would expect them to be tachycardic, but this is still stuff you need to look at. But tachycardia usually accompanies hypoxemia in adults. Bradycardia usually hints at anoxia with imminent cardiac arrest. So they start tachy. Once they start difficulty breathing, they start hypoxemia. As they start into the hypoxemia, as that progressively gets worse, then the heart rate is going to start trending down. So you're going to initially go from normal to tachycardic, and then trend back down to bradycardic as anoxia sets in. And if anoxia sets in, you may be looking at imminent cardiac arrest or stoppage of the heart.